are live. Hello and welcome everyone. We're so delighted that you're joining us for this session this morning. Welcome, welcome. I'm Jocelyn Clark from the Lancet, and it's my pleasure to welcome you today and to be part of the Lancet Commission on Gender and Global Health, which is co-chaired by our speaker today, Pascale Allotey, whom I'll introduce to you in a few moments. She's joined by our other co-chairs, Sarah Hawkes and Asai Elhadj. We get to work with an incredible group of commissioners from all around the world, many of whom who have joined us live today. And we really want to thank our other colleagues on the team, Emma Rule, Anna Purdy, and others for really bringing this seminar series to life and helping us create what's been a really interesting and enriching program. And I have no doubt today is going to add even more to that. And I'm just thrilled that you've joined us. So let's kick off because we've got a defined period of time, and we'll ask, if we may, that all participants other than our speaker turn off their videos so that we can optimize the broadcast, and also encourage you to put your questions to our speaker in the YouTube chat box, and I'll be putting those questions to Pascale when it comes to the Q&A. So let me introduce our speaker for today's talk on gender equality and decoloniality in global health. Professor Pascale Allotey is the director of the United Nations University International Institute for Global Health, a position she's held since 2017. She's a midwife and a public health research in global health covers health equity, health and human rights, gender and social determinants of health, migration, sexual and reproductive health, tropical diseases, and non-communicable diseases. And she's published extensively on all these topics. She's worked in several countries in Africa, South Asia, and in Australia, and she's pioneered methodologic approaches for engaging communities in research.
The last time I felt this nervous about a presentation was about 15 years ago for the inaugural lecture of my first professorial appointment. I had taken that as an opportunity to engage in a dialogic reflective process, acknowledging that though I was supposedly at the pinnacle of an academic career at a relatively young age, I still didn't feel like I had the answers expected of me. I still don't think that I have the answers. But what I do bring to this conversation is a reflection on a range of professional experiences, conversations, relationships, and knowledge that interact with who I am and where I am geographically and in my career. The ideas I share today acknowledge that this ongoing dialogical process results in a range of ideologies that are more depending on the particular circumstances. And so I humbly offer these ideas up for consideration, comment, and debate. Next slide. So the pandemic has been useful for a number of reasons, one of which is catalyzing certain conversations. So my general proposal today is that there are broadly two parallel conversations relevant to us happening within the context of equity and global health. The tools to which we default from the global health perspective may now have limited utility. And there's a desperate need for some creativity and opening up of the types and sources of evidence that are better able to integrate the complexities of today's challenges towards solutions relevant not just for the here and now, but also consider the health and well-being of the next generations. There is an increasingly irrepressible voice demanding that we address the inequities that impact on health and well-being. COVID has made that voice desperate, and where we can, we need to provide the spaces to amplify that voice and others like it. Otherwise, we are culpable in enabling and exacerbating inequities. Decolonization, next slide, Emma, has emerged as the new panacea to push us to tackle inequities at their source. But is it? And if it is, how can it be properly deployed so that it is effective? Next slide. So in the work of this commission, we have chosen to tackle gender inequities in global health. Each of these terms is contested, variously defined and operationalized. While we as commissioners continue to discuss conceptual framing, we have chosen not to get bogged down in revisiting definitions and prose that have been pondered and constructed by generations of feminist scholars, researchers, academics, and practitioners. Instead, we are drawing on existing scholarship as a springboard to an action and futures-oriented set of recommendations that envision a world in which gender equality is real and evident in outcomes for health and well-being. We acknowledge our differences in disciplines and perspectives, but collectively share the outrage of injustice that is deeply pervasive and ingrained in our systems and structures. So that's the warm and fuzzy part. But the dilemma, I think, and I think it's a real dilemma, is that we do this from the boundaries of global health. And we are reminded regularly that the output of this process is a report targeted at the Lancet health audience. So let's start there. Let's take that as the starting point. Global health is born out of the disciplines of the medical and health sciences, which fundamentally operate from a positivist reductionist standpoint. While the social and political sciences have gained some priority, the reality is that they remain the correlations of the real evidence that is valued in the field. This report is expected to fit into a paradigm that recognizes and embraces this solipsism. We expect that there are tried and true methods that measure up against a gold standard and generate potential solutions to fix identified problems. And in this way, we remain robust, structured, and objective. Subjectivism is indulged. The problem is that the inequities that we seek to address are not in the realm of the clear, tangible, positivist, and reductionist. Inequities do not conform to a disease model where the diagnosis serves up the treatment solution. But that is the model that we understand, that conforms to our way of knowing, and so we reduce the problems to be as instrumental as possible. We identify the problem and we try to find the widget to fix it. We try to push the square peg into the round hole. Next slide, please, Emma. And so social medicine, social epidemiology, political epidemiology, the social determinants of health, all make contributions to solutions of inequity. And indeed, some have. Where there's political will, the introduction of policies that intervene through welfare regimes, political approaches, and social policy have yielded results at a local level. And the material tangibles are fixed. And it is possible to ensure, for instance, access to healthcare services through the right financing models of universal health coverage, but not to address the underlying factors that lead to poor health. We provide the evidence for the investment in disease, but not in the production of health and well-being. Next slide. And the next one. So gender and indeed inequities and indeed other inequities are rooted in our cultures, our systems, and in what or who is considered important or value of value. One of the news stories in Malaysia this week, in addition to COVID, is of a teenage girl who has called out her male teacher for making rape jokes in the classroom. The story went public and the rancor, the death threats and threats of rape are unbelievable. As a response, and these are as a response to a campaign that she started, which is a hashtag Make School a Safer Place. And it still blows my mind the extent to which we talk about the critical importance of community health workers and nurses and other non-medical staff, mostly women, in the health system in general and in public health in particular. And yet the society's indicator of value, the salary package, in no way reflects that we value frontline health staff. Indeed, there are internationally funded projects and interventions to help motivate community health volunteers to deliver better in spite of the lack of remuneration. It's outrageous that women who are bullied or face sexual harassment or abuse have to be the ones who change what they do and where they go to be safe, while institutions that claim to know better still protect perpetrators and themselves from reputational damage, because it is still so much worse to have had such an incident than for them to step up and make a strong statement that it is not acceptable for a senior academic to take advantage of a junior colleague. It is shameful that in 2021, organizations that have a mandate to address inequities and injustice continue to perpetrate abusive practices within their own organizations and even externally in communities they are supposed to protect. Feminist organizations are not immune from cultures of bullying and devaluing staff based on ethnicity, caste, class, age, and ability. So with this level of pervasiveness, it is perhaps unsurprising that for the most part, there has been a tendency for public health approaches to default to that which is safe. Tackling equity and inequity is uncomfortable. And perhaps inherent in the safety is an attempt to control how much we are prepared to give of the privilege of our institutions or our disciplines. We now have to acknowledge that these issues are just as pertinent to us as individuals, to our own institutions, and to our ways of doing and being, and they harm us, they harm others, and they make us ineffectual in a quest to level the playing field. We need to position ourselves in the inequity solutions and trust that we have the power to push back and contribute to alternate framing. But I don't know that we have the tools to do this sort of thing within the current ethos of global health. Our tools have us attempting to fix the problems for them, those others that are minoritized or marginalized. Our knowledge gives us the righteous authority to lead the charge in attempting to right the wrongs in the way that we know how. Next slide. So where does decolonizing fit into this? The decolonization movement draws on the emotiveness of inequities and the inability of global health, as it is currently defined, implemented, to address these emotionally raw, deep-seated inequities. It is noteworthy that the symbols and images of decolonization are often combative. Decolonization is certainly not new, and there's an extensive body of work going back to the 1930s, probably, and there are preeminent scholars in philosophy, ethics, sociology, politics, and development who have done a lot of work in this area. Decolonization calls for a breaking down and reversal of the injustices and impacts of colonialism and neocolonialism, the systems that are the origin of today's injustices. For global health, these ideas are relatively new. So since 2019, we have been monitoring the growth of decolonization in the global health literature. And if I may, I'm going to now ask my colleague, Dr. Emma Rule, who has led on this work, to just give a very quick overview of the landscape. Emma.
Thank you very much, Pascale. So we set out to explore who is writing or thinking about decolonizing global health and what they're talking about. We ran a literature search spanning papers, articles, and blogs, amongst others, published since 2000, using the search terms decolonize or neocolonial and global health. In defining global health, we drew on a description by Paul Farmer and colleagues as not an academic discipline, but a collection of problems that turn on the quest for equity, very much the point that Pascale has been making all the way through, rather than the more simplistic approach of public health somewhere else. As such, papers addressing Indigenous health equity in settler colonies, for example, were eligible for inclusion. From an initial 207 papers, there were 83 that met the inclusion criteria. And what was notable was the uptick in publications over the past 5 to 6 years. 87% of the papers in our study have been published since 2016, and nearly half of those were published just since the beginning of last year, with a 5th published in the first 3 months of 2021 alone. But we wanted to understand where the drive to decolonize global health is coming from. Much of what you read references student movements at universities in the so-called global north, for instance, Harvard or the London School. As such, there's a real risk that the decolonized narrative is in fact being colonized. So we chose to look at the institutional affiliation of first and last authors on these papers. We chose institutions, not nationality, because ultimately this is a conversation about power. And being associated with a powerful global health institution provides individuals with a platform, impacting who and what is heard. The location of these institutions and all the associated history gives these authors a voice and influence in the debate that colleagues situated in the global south often lack. So if you look at the selection of first author papers, and I appreciate that you cannot read these charts in detail, what I'd like to do is to draw your attention to the small part of the pie in purple. And this represents our authors who are situated within countries within the global south. And as you can see, they represent a depressingly small percentage of the thought leadership that we're seeing. We also looked at last authors. While some of our papers explicitly said that all authors had equal contribution, the reality is within the medical field and global health, the last author is often an indicator of the most senior person in the discussion. And again, you can see just 20% of our authors are leading the thoughts, leading the conversations from institutions within the global south. I should note that there were a number of papers that did have representatives from people in the global south, but they were sandwiched in the middle. So now we know who's writing. What are they writing about? We classified the papers into themes based on the main content of the paper. Unsurprisingly, the bulk are talking about decolonizing global health in general, and 88% of those papers have been published since 2019. We were also interested in understanding the 3 main pillars of global health. That is knowledge production. Who is doing the research? From where, on what, and how is it prioritized? And then the dissemination of that research. It included publishing, but also conferences. Who gets to control the narrative? What are they privileging? And what voices are missing? And then finally, funding. Who is paying and what are they buying? As you can see, there's a lot of focus on the former, and there's been a lot of discussion on both on the research and production side, but surprisingly, not that much on the funding, which is interesting given that money equals power. When it comes to practical application, decolonizing education is one of the main areas. And in fact, it represents some of the earliest papers in our review, covering the content of curricula, the methods of teaching, such as problem-based learning, and criticisms of international immersion experiences, and who really benefits from these abilities of students from the global north to spend time in the global south and the advantages that that brings to their career. However, just 2 papers were focused on the implications for policy. Both of these were from former settler colonies, Australia and New Zealand, one of which was co-authored by our own commissioner, Fran Baum. Again, interesting questions here about how much further ahead countries where former populations that represent colonizers are living with indigenous populations and the way their conversation has progressed. Whilst every paper articulates what the problem is, there are far fewer that articulated solutions. Some of the solutions, especially early on in time, were in some respects quite intangible. Be more aware of cultural factors and differences, promote diversity and inclusion, be reflexive. Others are much more practical, including diverting funds to institutions and individuals in the global south, the use of decolonized methodologies, and increasing inclusion of and engagement with affected communities. But from all that we read, what really jumped out was this. In all the discussions on the need to radically reimagine the system, there were just 256 words, a single letter written to the editor in response to a piece published in the Lancet addressing the subject of accountability. So we are pushing for change, but who is keeping track of that change and who are we being accountable to? Pascale, back to you.
Thank you, Emma. So the review for us has opened a number of important thematic areas from a global health perspective. If funders and funding models are a part of the problem, what is the solution? Would governments and researchers in the global south rather not have access to funding from the global north? Given the power of resources, is there a world in which recipients can dictate the conditions under which they are prepared to accept these resources? Two, there are funders that have made changes to account for the need for locally driven solutions. Is this the decolonized model that we're looking for, and are there best practices? Three, there are multiple agreements about ethical partnerships, respectful engagement, and so on. But how is anyone or any institution being held to account? Four, there is an unfortunate polarization in the discussions, and I believe this goes back to the deeply personal nature of the perceived injustices. Those perceived to have some power and agency, and those who potentially stand to lose power and agency in a decolonized agenda. Again, for global health, this gets messy. There are no clear experts delivering knowledge, just a problem with lots of people with skin in the game, with skin in a game that is by definition requires that all voices are privileged. Which begs the question, what does successful decolonization look like? Who is required to deliver it, and how can they be held accountable? And from a more provocative perspective, I think there are another set of questions, which is what is the absolute crux of the injustice of colonization? What is it we want to see reversed? Because one of the things that we cannot do is turn back time. We can't unlearn decades of history. That would be like throwing the baby out with the bathwater. And decolonization has been appropriated as well as a proxy in movements in anti-racism, gender equality, inclusion, and diversity. While there are certainly elements of colonization that have contributed to these inequities, they are a reflection of so much more of what is wrong. How do issues of gender, race, and other inequities intersect with decolonization? How do we draw together these agendas towards a just and equitable global health without creating competing vulnerabilities? The decolonization agenda is a call to recognize a past injustice, the impact of which has persisted. The passion of this has been captured in several seminars that I've had the privilege to attend that have been organized by scholars across Africa. Most notable for me was the Health Systems Africa convening that was led by the Atlantic Fellows last year. So this is clearly an area that is going to keep moving. Next slide, please, Emma. So I need to acknowledge, what does this mean if decolonization is the language that we want to use? How do we think about righting the wrongs? And in this, I need to acknowledge here that I'm borrowing heavily from my son, who did his honors thesis on an analysis of the apology. If we were to take a decolonization agenda, as is captured in much of the work in this area, we would need to explore the range of reparations required for healing, models used, for instance, in peace building and nation healing processes. And in some ways, the call to accountability for institutions that do not follow up on their commitments to gender is one that is a call for reparation, for recognizing that they have wronged a whole lot of women and disempowered them. Now, for this approach to seeking redress, it does require the recognition of wrongdoing, empathy, and a preparedness to give up something. Power, resources, something. People have to give up something for equity to be achieved. It is not necessarily a zero-sum game. And then could we imagine that these may have an impact on health and well-being if integrated into our interventions to counter the misogyny, patriarchy, and racism of our systems and institutions? So I'd like to quickly wrap up here with reflections from a discussion, and I've spoken to so many people about this, with reflections from a discussion with Arathi Krishnan, who is one of my really brilliant colleague from UNDP who works in the area of strategic foresight. The reflections are that if we think of colonization primarily as the domination of peoples and communities and the discrediting and destruction of civilizations, cultures, and ways of life, decolonization needs to be a project of reversal. I'm not sure we can unlearn we can unlearn that which has brought us to where we are today, but we can engage in a process of rehumanizing. We can only do that effectively by being reflective of who we are and what we bring to particular discussions. We need to be able to question if we are the right people to hold this conversation, because who is at the table does make a difference. And critically, she makes a distinction between decolonization and decoloniality, which she defines as a process of relearning from the cultures, constituents, communities from whom these social goods were wrenched and whose knowledge was discredited. It provides an entry point into restoration, renewal, rediscovery, and it opens up to the possibility of how we might coexist, abandoning the solipsism of global health framing and embracing a plurality of knowledge. This, for me, is central to the process and outputs of this commission, that we come to it recognizing the enormity of the task of seeking redress for gender equity and gender justice in health, that we recognize that we are going to have to go beyond the box into which global health puts us, and enter into a dialogical learning process for solutions that could see sustainable change beyond us. Decoloniality provides an opportunity for reversal, not to turn back the clock, but to open up in a real way the space to privilege the suppressed and devalued ways of being and thinking. It acknowledges the plurality of voices and the plurality of evidence. Decoloniality offers a way, sorry, my notes just vanished there. Decoloniality offers a way forward that is central to addressing inequity, a willingness to listen and to be open to a world in which consultation process not only has very different people at the table, but also perhaps chooses that consultation does not mean being at a table. Decoloniality would push investments into our engagement with communities and with each other that acknowledges historical domination, disempowerment, and disrespect. Recognizing that who we are is an embodiment of cultures and societies that have been abused or were and continue to be the abusers through political, social, cultural, and structural processes. I'll end with an apology for the cutesy photographs, an acknowledgement and an acknowledgement to UNICEF for them. I am a sucker for babies, and they are a constant reminder that decisions we make and changes we engineer are not for us, but for them. I have had lots of conversations with family, colleagues, friends, and scholars that have helped to shape and continue to shape these ideas. And if I have spoken to you and you see your ideas reflected here, thank you very much. Thank you, everyone.
Oh, thank you, Pascale, for that wonderfully powerful and stimulating talk. I can't help but note your first slide to me really resonated. I am still learning, because I think as a professional colleague of yours, and I speak for all of us, I'm sure, that you are a tremendous model of continuous learning, and we learn so much from you. And in particular, this sort of humility and self-reflexiveness that at the same time delivers such a powerful questioning critique of the world and the ways of thinking that we inhabit is just remarkable, and it really sets you apart. So thank you so much. We don't have a lot of time, but I'm going to take a few questions, and I'm going to start with one. And if you don't mind, just keeping your responses super brief so I can get to at least two others. so much for us to digest, but can I first ask you, in what ways do you see this uptick in the movement around decolonizing global health incorporating, number one, the recognition of gender inequities, and two, the use of tools from a kind of feminist project in global health? That sort of explicit link seemed to me to be missing in your discussion and in Emma's wonderful analysis. Thank you, Emma.
Again, very, very quickly, I think so two things. One is that there is some danger, I think, in appropriating decolonization as a proxy or as an alternative to the work that we need to do in gender equity. I think there are sufficient overlaps in the issues, and I think it's one where we need each needs to inform the other, but not. I think there is some, or there have been some concerns, certainly in work with some of the other agencies, where it's seen that decolonization seems to be the language that we're using. So let's see if we can push all the work that we are doing in disability and so on, just to make sure that it doesn't get left behind. But having said that, the colonization process, obviously, and decolonization, as we think about it, clearly we can't separate out all the learnings and the misogyny and patriarchal systems that have come with colonization and so on. So that they are deeply integrated. And it is something that we're going to have to make sure we integrate in the work of the Commission, work together. Thank you.
Thank you. That's really appreciated. And I just found it striking in the data that you shared, Emma, that there wasn't, a label around gender equity. But I look forward to seeing your piece when it's published. Okay, a question from the audience. Pascale, if you will, what can the average person do to help promote the decolonization of global health and increase accountability within our respective societies?
Again, I think that was one of the things that I mentioned, that I do think, I think this is the cat's out of the bag. I think this is a conversation that will continue to happen. And I think the momentum behind it does allow for a whole, hopefully, does allow for a whole range of conversations that will now be privileged that possibly were not before. I do think that for any conversation that we have that deals with those sorts of issues, that we do need to think about what it is we're bringing to it, and we do need to hold people accountable for what they bring to the conversation, what they bring to the table. I just say to people, look, keep talking about it. It's not just, and it doesn't have to be the language of decolonization. It has to be a mutual accountability to each other, a rehumanizing, as I had said.
Thank you. And there's so much space and anxiety and yet opportunity within the context of a pandemic for all of our relationships and responses to be dehumanized. Final question, just with respect to the time, from the audience, Pascale. Often decolonization of global health seems to be led by academics, intellectuals. To what extent have communities, the grassroots, indigenous peoples, been part of and or leading the conversation?
So I know we have a few commissioners in the group who are experts in this area of work. It is actually a much more, I wouldn't call it mainstream, but it is a wider conversation than global health. So I want to be clear that we're not, or make sure that we're not talking into an echo chamber. These conversations are happening in other spaces as well. We're part of a process with a study that's been funded by Open Society, for instance, that is looking at reimagining development with a decolonization agenda. UNDP is doing a lot of work, again, also in terms of reimagining futures and international development as well. So I do think that there are quite a few grassroots organizations, but please, if you're out there and you're interested in the area, push it out, let the conversation happen, let people be uncomfortable, because that is the way we need to we need to engage with each other to try and resolve some of the equity related issues.
Oh, thank you so much, Pascale, for that response. And I think actually a wonderful place for us to end with such encouragement and such inspiration from your talk for all of us who have joined today. So I want to thank everyone who gave us your time today, and I hope you enjoyed this talk. I have no doubt you'll be going back to the recording, as I will, to absorb all the wonderful ideas and the critique that we learned. And before I say goodbye to our audience, I just want to remind you that the next installment of this seminar series is happening in 2 weeks on Wednesday, May 12th at 4 p.m. British time. That is going to be led by our colleague and Commissioner Gary Darmstead, and he's going to be talking about his recent Lancet series on gender norms, equality, and health. So I hope that you join us. And in the meantime, please don't hesitate to reach out. Delighted you were part of this seminar